Great. So 1:30, welcome everybody to EuroPCR 2024. I am Dr. Bernardo Cortese from Milano, Italy, and we are chairing here a session on the complex lesions and dealing on how we should prepare correctly the lesion. I have as a spokesperson Dr. Ajit Menon, and as discussant Stefano Galli, Stéphane Carlier, and Andrew Latvienk. So I think that only Andrew is lacking here. Yeah. So probably he will make a little bit later. So today, the aim of this session, which has been designed to correctly understand how to deal with the complex lesions. Because what is important is not only to deliver the final therapy for coronary artery disease, but we want to understand which is the best tool that we should use every time to manage the complex lesions in terms of microcatheter, in terms of balloon, in terms of optimization of the final treatment. It's pretty hot, I have to say. If it's possible to lower a little bit the temperature, I would appreciate. Thanks a lot.
Me too.
Yeah. So we completely agree on that. We'll see if we agree also on the discussion. I will have to present also a live in the box case, which is a very complex one, but we will have a lot of time to discuss. So I don't want to lose other time, and I'm asking Dr. Menon to present the first speaker.
The first talk will be on optimal coronary preparation with the new Wedge NC scoring balloon. I invite Dr. Stephanie Carlier.
Hello everybody, and really thank you for PROSMED to organize this symposium on a very important topic, which is actually scoring the plaque. And we will agree that there are always some conflict of interest that must be there. I always think that it's better to have many conflict of interest than only one, so I don't mind having so many listed. So we agree that our job in the cath lab is breaking rocks most of the time, and when you go to the basic histology and the work from the group of Renu Virmani or others, you understand why sometimes we have that feeling of being prisoners. Good news is that we are talking a lot on ways to escape these jailed coronary arteries by calcium. And for today, I would like to just focus on the approach that consists of precisely scoring the plaque in order to have a better stenting expansion after. And this is something that I've been doing for many years, and already in 2007 we were reporting from CRF, while I was working in the core lab, the results of the first angioscope trial showing that scoring the plaque, and that was for soft plaque, fibrotic plaque, or calcific plaque. You see that it's even better for calcium. There is a better stent expansion after, and that's a funny concept. That stent expansion is actually looking at the expansion compared to what you would get in air of a stent that is at 3.5 millimeters, set at 12 atmospheres should be 3.5, or at 16 atmospheres should be at 3.6. Really, there have been a lot of work done with the scoring of the plaque, and there have been numerical studies, there have been some studies based on OCT, where you really see the increased stress at the level of the scoring element that will very minutely intensify the stress and break the plaque just at the level, and this is the way you can prepare the plaque better. There have been this concept of the stent expansion that has been measured in other studies, and it has been measured also with OCT, and you see here some results showing that there was also a better expansion in this study. We were trying with the wedge, and please remind, this wedge was a semi-compliant version. There was one nitinol wire in order to cut the plaque, and we were looking at the stent expansion compared to a conventional semi-compliant predilatation. We were enrolling up to 78 patients, and we have been treating up to 95 lesions. These data are going to be shown on a poster by my good fellow and colleague, Dr. Ghaffari. This is a poster where he shows the methods that we were using based on some stent enhancement techniques in order to measure in multiple views this stent expansion, and this is something that we can assess before and after post-dilatation. There were no difference finally between these two arms, and you see that the stent expansion for the conventional arm or the wedge was the same. What we saw is that there was a difference in the successful crossing of the lesion with the wedge, and in the same time we saw that there were more balloons used non-compliant in order to better prepare the plaque in the conventional arm. There have been many measurements, and Shadi is going to present this PhD thesis on this Friday, actually. And he has been doing all the core lab analysis. You see that there is here no difference in the average stent expansion. We did some IVUS, we did some scientific data, but let's go back to one case. You see here, this is, I would say, quite calcified lesion at the ostium of the circ, and you see by IVUS that this is a heavily burden of calcium. You see some ring, so it might be not too thick as we know, and we know that in this case, if we want to prepare this optimally, we will have to better score the plaque, and this is the wedge that we were inflating just at 7 atmosphere, and you see that some remaining print on the balloon, but you see that with IVUS, we clearly see some crack already in this. So this is enough to go further and do some stenting. We were comparing the stent expansion at the nominal pressure, and then we were doing some post-dilatation, and this is finally the results with these patients, and you see that we were obtaining quite good expansion. I think that we were missing this one, the wedge non-compliant, because then there is a very high rated burst pressure, 22 atmosphere, and we can go then with a device that has a very nice small profile. There are then possibilities to better crack this calcium, and there have been already some data from China shown here. Those 9 centers were including 99 patients, and they clearly saw a difference in the acute lumen gain in the minimum lumen diameter reach and the diameter stenosis. This is before stenting. So we have this Wedge NC also in the lab now, and we have been doing some case, and you see here a nice case that was first a patient seen preoperatively with some ischemia. We do the coronarography, and this is a lesion on the right that we choose to treat with some scoring of the plaque and some drug-eluting balloon, and we see some interesting results at here. Couple of months later, you see a very nice results, and yes, in the same time that occluded circ that we will address after his hip operation, and this is what we did more recently. You see that we were trying to find a better way to visualize where to go in this distal circ, and we can see here that it's not right at the bifurcation that the stump is. It will be a bit further down, so we take just a Fielder XT and a Pronavi 1.7 French catheter, and you see that we are not able to cross easily with the Fielder XT, so we go for a better penetrative wire, the Gaia 2, and finally we succeed to reach the distality. And this is now the right time to do again IVUS in order to, after predilatation with a 2.0, assess a very large burden of calcium. We see again some rings. This is really at the level of the bifurcation. Please remember there is a wire here. That's always easier to find your way back and co-register this image. This is the results that we have after scoring this CTO. So please remember, just 2.0 semi-compliant balloon, and then you see the wedge going through the lesion very swiftly, and it goes, it will prepare nicely. You have to turn the balloon, you have only 1 wire. This is going to be better with 3 wires now, but you see that there is a very nice preparation of this CTO body, and there is now time to do some stenting. What we did finally, and this is the final result that you can appreciate, this is so complex PCI, this is CTO, this is scoring the plaque. I would like to conclude saying that if it is important to crack these plaques, the Wedge NC scoring balloon delivers very well, and with a rated burst pressure of 22 atmosphere, it gives a clear added advantage for adequate lesion preparation. The fact that we are controlling the dissection and we are precisely preparing the plaque allows us to do some hybrid therapy, some drug-coated balloon strategies. And it is interesting to think that this is what we have today, but tomorrow we will even have better device scoring the plaque with this Revo Edge. And I cannot wait to be using this one in my cath lab. I thank you very much indeed.
Thank you, Stefan, for these nice cases and for the study also. I have a question. You have shown some cases of highly calcific lesions managed with a Wedge NC. Which is your cutoff in terms of information that you gather with intravascular imaging between using atherectomy or IVL, or you say it will be enough to go with a scoring balloon?
Today, when I look at the price of a Wedge NC and I look at the price of a rotablator, I will first try the Wedge because it is an easy palpation of the vessel. And if the IVUS catheter doesn't cross, I don't mind. I can still try with some scoring balloon. The scoring balloon doesn't go through. I can take a 2-0, like you see. We do not CTO with straight a scoring balloon. You prepare the plaque, you can try to do some imaging after your 2-0 semi-compliant, but then after you go for a 0.8 to 1 ratio, and you crack the plaque, and that's what you want to have with precise preparation, not a spiral dissection going all the way down the artery. And I think that you like the idea of combining this with drug-coated balloon, but you were publishing a study where after drug-coated balloon, there were less optimal results on the long term with scoring. Can you comment on this?
Well, that was the PREPARE study you are mentioning. We published it last year. Actually, it's a retrospective study, and the results were a little bit debatable. Because there was a high selection of the patients. And in that study, the highly calcific lesions were managed with atherectomy. At that time, we didn't have orbital, we just used rotablation or some initial IVL because the study was done in 19 or 20. So I cannot tell you. We are managing that and trying to understand that with Picoletto 3, actually, because there will be 2 randomizations. Mm-hmm. The first one will be between semi-compliant or non-compliant versus scoring balloon. So we need this type of data.
Yeah, I think so. That's clearly a need in our field.
Stephen, congratulations. Regarding the point that is exploring with Bernardo now, only technical point. When you prepare in the DCB, do you use 1-to-1? Which is the pressure? Which is your feel before DCB? When you are in mind to use the DCB in de novo?
0.8 to 1.
Okay.
Not 1. I mean, you are going to break everything and you are going to have huge dissection. But then you go as high as necessary to see the balloon and really. You know that I like to do some IVUS, but yeah. I cannot afford this all the time, but I can always do a stent boost on the balloon and see the balloon expansion. And you see the wire, you see the cutting elements that are straight or not, and you have to look in 2 directions. Yeah. Then you can do this with the stent after, and that's all the thesis of Shadi, but that's very, there are a lot of information looking in the wall of the artery from a stent boost image.
Okay, thanks.
Stefan, wonderful presentation.
Thank you.
Just a couple of questions. One is, where would you select an NC wedge balloon and where would you use a semi-compliant wedge balloon? Because
I think the semi-compliant, there's no more there's no more room for a semi-compliant scoring balloon. I think that we should prepare the plaque with high pressure scoring device.
Right. And when you're talking about drug-coated balloons after any scoring balloon, which is coming, which is a lot of papers on it, would you recommend that in proximal LED or proximal circumflex lesions in the real world scenario, would you still recommend that you would do a scoring balloon and just a drug-coated balloon, or would you be a little wary about that?
It's interesting. I used to say that I started to do PCI last century now. And last century we were with Patrick Serreus doing the debate trial, where we were flow optimal PCI results with a balloon versus stent. And if you had a good flow and a good coronary flow reserve, you could leave some dissection, and that was the concept that now you can even do a better job, I think. If you have a good flow, if you don't have flow limiting dissection, you go there and you put some paclitaxel or whatever you want, limus, that will be even better than debate.
Yeah, I fully agree that you will need to create some room into the media to let the drug penetrate better, mostly in a highly calcific lesions.
And if you don't see the dissection, and sometimes the fellow is telling you, yeah, but there is some stain, I think that's normal. I mean, that's how you break
That's the way, how it works.
It's how you escape that jail.
Yeah. That's fine. I think we can move on to Stefano. Stefano is presenting us a pot and wedge, how to prepare and optimize PCI.
Thank you. Big thanks to the Brosmer for invitation. And so, pot, every day we do a pot, every day we told about pot, but how do very well pot? So pot to optimize proximal to carina, to optimize post-dilatation. It's very important to avoid geographical miss and to avoid trauma outside the stand, and pot to modulate high pressure post-dilatation in the ostium, for example, left main, and to flare ostial stand. But pot with dedicated balloon. Today, in the case in the main arena, we see the pot with a balloon outside stand over the carina. So it's very important, the short length and the cube shape shoulder. And dot is distal. Obviously, normally we don't use every time, but when there is an inverse discrepancy between a vessel diameter across the bifurcation in Medina 010, or to correct distal stem malposition or distal under-expansion or in tandemly bifurcation lesion. So this is a concept of pot to avoid under-expansion proximally, but also to avoid the overstretch over the carina. Which is the risk to overstretch the carina? The risk is to carina shifting, pinching the carina, and sometimes we know very well if the lesion, there is a lesion or there is only the move the carina. And also the possibility to rewiring, if you do a pot very well, is better. But not all balloons are equal and not so the same characteristic to perform a pot, semi-compliant, compliant length, but it's very important the shoulder length. For example, if you have a shoulder length longer, the risk to go to proximal sometimes happen when we don't post-dilate after delivery the stent, that the distal portion of the stent are under-expanded. Nevertheless, if the shoulder is too big or outside the stent, the risk to traumatize the edge of the stent is higher. We need the short balloon, but with the shoulder very, very short. Now I show some casing. This is a simple case where there is a big discrepancy between proximal and distal bifurcation. And after stent boost, we see very well the under expansion of the proximal vessel, and we perform with a pot balloon a little bit more than the carena and go up to the atmosphere to avoid, like in this case, lose the diagonal vessel. This is another case where the pot is crucial. This is a bifurcation lesion where is involved a left main, the ramus and the carena, and obviously the ostium. And we decide to prepare very well the lesion, and then we do a DCB into the ramus, and then we perform a mini crushing, pot, tree kissing, and pot, but we choose the sizing of the pot balloon 4.06 millimeter with the IBUS guidance. And also after pot, kissing pot, okay, the result is good, but if you go inside with the imaging, we see very well that in the proximal portion, a part of a lot of rewiring, the stent is well opposed, very well open, and also the carena is 8.5 millimeter square, and also the ramus, the LAD ostium, the circ is very open. This is a case with a complex case where the device, a lot of devices are useful. This is a case with a long lesion in proximal and mid LAD with a big discrepancy between a reference vessel, but important point that there is a stent that protruding in the left main. You see very well into this imaging of IBUS into the left main, and difficulties to move the other catheter. In this case, we use a lot of different size of pot, 4.5, to crash the stent against to the left main wall, and then to prepare very well the lesion. But the other stent is in the distal portion, like this, is not well open, and we use another pot balloon at high pressure to prepare very well. After preparation and after pot, and we decide to put a stent, but obviously if you remind the imaging, there is a lot of discrepancies. In this case, we use a 3.5 pot in the mid portion, and in this case is the dot procedure. Use a 4.0 balloon distally to the carena and 3.5 proximally to the carena, because there is a discrepancy, and we can go directly with a long NC balloon. Okay, is possible, but the risk to compromise the bifurcation is high. At the end, after preparation, we see very well, and we see the ostial LAD, we see the stent crushed against the left main wall, and then we see the distal left main and the carena. And another case where the pot is crucial, but I believe this need a short balloon. Is this case, the decay culotte case. We prepare in this case with circ and LAD with wedge balloon 3.0, and after preparation we decide to, I believe that is better to cross the circ, and we perform a pot with a short balloon 4.0, and then we see the possibility to rewiring. In this case, I go too fast, and it's not so easy to recross LAD, but normally after pot is very, very easy. Now we, after this is in live, I try to move gentle to avoid the dissection, and then after move a little bit, this is a cyan blue wire, we gain completely the lumen. Now we see, and this is important because normally I see a lot of time the crossing the side branch before pot. I believe that rewiring is better to do after pot, and then like some second we gain the lumen and go into the now finish into the distal LAD. Let's go. Okay. Now we redo a reopening cell, you put a stent, we redo a culotte, and then obviously after a culotte, in this time, in 5 seconds, we rewiring the circ and redo a bifurcation and finally redo a pot. After we check with the IBUS, and the IBUS show to us that the works is good, the lumen is very large, and I believe that is a clear demonstration. If you use correctly the device that we have in the lab, the result is better. So I believe that it's very important, POT, but POT not only the name, but to use correct device and choose the device in base of characteristic properly for this technique. And I believe that is not only pot, but sometimes it's very important to do also the dot. Thank you for your attention. It's very.
Thank you, Dr. Stefano.
It's very hot session.
It is very hot. That was a wonderful presentation on multiple types where we've used the pot. I think pot is one of the finest balloons that you can use in terms of proximal optimization. Any comments from the panel?
I've got a quick question. So, great talk. We've got the pot balloon on the shelf, and I have to say it's quite satisfying to see the very sharp edge. And kind of intuitively, it makes sense. But do you think, because we worry about the shoulders, and certainly we know that if we misplace our pot, we can cause problems with the bifurcation. But do you think we need to demonstrate that using the pot balloon we're not disrupting our stented bifurcation as much as with a standard NC balloon used for a pot? Do you understand what I mean?
Yeah.
I think we need to actually demonstrate through a study that these pot balloons are superior, or do we have enough information already?
Yeah, this is difficult to answer. Obviously, sometimes we need, but sometimes in our job we do a lot of things that we have no a big evidence, but we have a feel. I believe that this is a typical case. No, this is a device correct use. Obviously, if you use a short balloon correctly, probably the result is not so different. But for example, sometimes I see that when you put in the LED, for example, and you cross for 5 millimeter and they use at 20 atmosphere 8 millimeter length. Or okay, we see the clear stand and go more distally and we put the stand against to the carina. So I believe that I need a demonstration. Yes, but my feel that do a lot of bifurcation is very useful device. And the characteristic of this device is very useful for us.
I like when you say that not all balloons are born equal.
Yeah.
But I would say that for pot, not all stents are also born equal.
Yeah.
And can you comment on those problems of overexpansion? Some of the stents you are going to ruin the procedure.
Thanks for this question. Today we discuss a lot regarding port technique to prepare the lesion, but we know very well the characteristics that the stent we use. For example, sometimes I see, unfortunately, to put 2.5 into the proximal LED, then I go up to 3.5. Okay, it's possible, but distort a lot. Or use a small stent into the left main. Then when you go to the pot, okay, we choose also the 5.0, but the risk to broke stent or to distort is very high. So there is a combination of preparation, device, and characteristic of the device that we use. Absolutely, yes.
All right. Actually, the pot balloon reminds me of there used to be an old Schneider balloon called the chubby balloon.
Yeah.
Way back in the 1990s, and that used to be a small circular balloon used to dilate stents just inside the stent.
Yeah.
But that is a much more compliant balloon. Thank you, Dr. Stefano. I think we'll go on to the next topic. Dr. Bernardo will present us a complex case.
Yeah, Stefano, you had a very successful presentation also in being able to reduce the temperature, actually. I'm going to, just to start and let it go, a recorded case. So welcome everybody to EuroPCR 2024. Today we are showing the importance of a correct lesion preparation before final treatment, either with drug-eluting stent or drug-coated balloon in a complex lesion setting. We are showing the case of a patient, a lady, that was refused by the cardiac surgeon due to previous radiotherapy at the chest for cancer. So we had to manage that in the cath lab. This patient also has a reduced left ventricular ejection fraction. We were understanding and were trying to use Impella for this case, but technically we were not able to do that. So we decided to use aortic counterpulsation in a bailout fashion. So now let's see how is the case. Good morning, EuroPCR. This is Dr. Bernardo Cortese. Today I'm from Cagliari, Brozzo Hospital with Dr. Angelica Rossi, a good friend for this live case today. And we are here with Serena and Massi that are assisting us in this quite complex case of CTO of an LAD.
Hi there. Thanks, Bernardo, for this great opportunity for my cath lab, for our team, and welcome in Sardinia, Brozzo Hospital of Cagliari.
It's quite cold, but Sardinia is wonderful as usual. So today we have a case of a 71-year-old female with diabetes, and this lady came for an acute coronary syndrome. Left ventricular ejection fraction is quite reduced at 35%, and she has a three-vessel disease. You can see in the images that there are two CTOs in the distal RCA with a diffuse disease, calcific lesions, and the LAD is occluded in a mid part after a lung disease, including also the left main. The idea here is to use a microcatheter, a Pronavi microcatheter, which is a microcatheter with a good pushability. It's hydrophilic in the last part, and it's able for, hopefully, to help us in achieving the distal lumen of the vessel. And the idea is to use a Fielder XTA to manage that. Save, down. Save, down. Aspetta, devo ancora vedere. Okay, save. So now we are dealing with the lesion. We are using an Alveo HP, which is a balloon dedicated for CTO, the very low profile. But the advantage is that you can use it also at high pressures. You can go up to 20 atmospheres. Again here, up to 20 atmospheres. Okay, we go to 20. This is a 1.5 by 10. Okay, so you can see here that after a predilatation with a 1.5 balloon, the vessel is still not open. But as I said, there is a collateral flow from the RCA, so there is some competitive flow. Now, we want to, after having protected the diagonal branch, we want to increase the size of the balloon. We are using an RTMS, which is a sort of semi-compliant workhorse, but you can see that it has a pretty nice deliverability. Okay, you can inflate it here slowly at 4, 5. There is a quite big calcification more proximally. The balloon is not well expanded, so it's not strange. So down. Because the idea is to do imaging, but I'm not sure if we will be able to visualize the CTO with the OCT. CTO with the OCT. Because it's quite, the flow is not very optimal for the OCT. So now we are dealing again with it, and then we decide where to do the OCT. So again, 10. Down. Here you can see that the balloon is making some difficulties in expanding in the calcification. So we are with the RTMS, we are at 14, 15. Okay, let's try 16, 17, 18. Still there. Okay, down. So we don't want to force this too much. We are going to assess it with the OCT now. Lesion preparation, this is the aim of this course, is of paramount importance, but it should be done in a stepwise approach assisted by imaging. So now we were not able to cross with the OCT, so we are crossing to a scoring balloon because we need to have more room for doing the imaging. Now we have used a Wedge NC, which is a scoring balloon with a nitinol wire, inflate at 4. This is a 275. Grafia. Okay, stop. Sto a posto. Vabbè. 10, 12, 14, save down, giù, 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 giù. Okay, so a few seconds for you were 60 minutes for us, because the patient unfortunately had developed a cardiogenic shock, and then she also had a cardiac arrest due to the blood pressure, which went very, very down. So we had to call the anesthesiologist to intubate the patient, put a counterpulsation to achieve a nice blood pressure that allowed us to go on with the case. So what we did afterwards was to manage the left main disease. We put a stent, a 3.5 by 30 from the ostium of the left main versus the proximal LAD. Then we did a kissing balloon with the circ, which was open with a balloon in a provisional stenting approach. I'm going to stop this because it's quite interesting to understand the pathophysiology of what happened. So probably we squeezed the lesion at the ostium of the LAD and the distal left main, and this created a shift of the carina versus the circ. The circ was paired. Circ was okay. The ostium you have seen by the OCT, it was okay. So we squeezed the carina, we moved it, and then the patient with this reduction in left ventricular ejection fraction went from a mild mitral regurgitation to a severe mitral regurgitation. Because when we called the anesthesiologist, we also asked the echo guy to come and do a fast echo. So we had a 20% left ventricular ejection fraction and a severe mitral regurgitation. And then we use a POT, non-compliant balloon, for the dilatation of the proximal part of the stent in the left main. That was pretty nicely done with a POT, non-compliant balloon, which has very small shoulders and allowed us not to go into the proximal LAD. And that was good. And then we went again in managing the proximal and mid LAD. We went again with a scoring balloon 3.25 in the proximal LAD to reopen it nicely, because according to the OCT there was still a calcification and recall that had to be managed somehow. Then we reopened, as you can see. Okay, inflate at 8. We reopened the CTO, which had again a recoil, and now we are using a drug-coated balloon, 12. This is one of the latest generation drug-coated balloons, Restore. It's a paclitaxel-coated balloon with an amorphous formulation, 14. So there is no risk of distal embolization that you may have with some other types of drug-coated balloons, so in a crystalline formulation. So now we're inflating the first Restore at the site of the CTO. It's 30 seconds. And now we would like also to manage the proximal part of the LAD. Let's show the last angel. This one. Okay. Which was prepared with a scoring balloon proximally. And now we would like to manage that also with another drug-coated balloon. Okay. So this is the Restore drug-coated balloon with an amorphous formulation. You can see that there is no flake of paclitaxel on it. Okay. Come si vede tutto. Okay, so now we have delivered the drug with 3 drug-coated balloons, paclitaxel. Now we are waiting. You can see here the acute result. Now we are waiting a few minutes. In the meantime, we will finish the optimization of the stent in the distal part that we are doing now, because we were not able to know if we had to put another stent. But now we would like not to put another stent, so we are optimizing it again with another pot, non-compliant balloon. And then we'll assess it with imaging. This was a 3.5 pot non-compliant balloon, or approximately. In this case, it was a distal optimization.
8,
10.
10.
In the end, after the orthogonal view, we had this nice dissection, which is not really nice. So in the end, we decided to put a stent, which is a 3.0 by 22, and now we are post-dilating it. So we think that we can finish here. The stent was optimized. Unfortunately, we had to fix all of the part treated with DCB because of this, I would say, nasty dissection in a patient with low blood pressure, adrenaline. So during the weaning, there could be lowering the blood pressure. So I wouldn't be happy leaving this type of dissection like that. So we fixed them. So the distal part, the CTO, was managed with the DCB. We can intend it as a final treatment, hoping in a positive remodeling of the DCB, hopefully, or as an investment procedure in the next few days to see what is going to happen, because this patient will need to be treated for the RCA. So that's it. Thank you. Also, the circ is okay by the OCT. The diagonal branch is okay. What do you think, Angelica?
That we can we'll check it in a few days.
Yeah. All right. Thank you very much.
Bye. Goodbye.
Bye-bye.
Wonderful case. It basically demonstrated wonderful planning in terms of what materials to use, what to use, how to plan a procedure. What would you think about the? I mean, when the patient went into cardiogenic shock, I thought there was some. Was there a lesion at the ostium of the circumflex at that point?
It was
It's just a plaque shift.
Yeah, there was a shift of the carina.
Just of the carina.
Shift of the carina. So we had a 80-90% stenosis of the circ, which was a very vital area of the myocardium. And then really you can see that, I don't have the images of the echo, but you can see it that the mitral regurgitation was very severe. So what did I think when the patient developed? I would have liked to use the Impella since the beginning. So that's the thing that I was thinking at.
A lot of times when you have a gut feeling to use something, it's always better to use that, because eventually you will end up using something.
You can stop it. Too late. Thanks. Yeah. That's how it works.
Any other comments?
There is also a microphone there if somebody wants to comment or ask questions.
Just to know, what did you do to the circumflex when the plaque shift occurred?
We just did a dilatation, then we implanted the stent in the left main, and then with the OCT, the ostium of the circ was okay, so I prefer not to distort the stents, the struts there.
Okay, thank you.
I was just going to comment. I mean, it's interesting that you said about wanting to use Impella up front, and obviously you're saying that having done the case, but presumably that was your view at the beginning. We're taking part in the BCIS CHIP 3 trial in Leicester, and that's in high-risk cases, so severe LV impairments where you're using calcium modification and the jeopardy is high. The exact inclusion criteria is slightly more nuanced. And those patients, you can predict that they're going to be more unstable and more challenging. And I think, you know, the more you do cases like this, the more you realise the ones that you're likely to run into problems with hemodynamically. Well, at least that's my view.
Yeah, as I said, I agree with you. As I said, this is, if despite the data are, yet to come, But I totally agree that in this case, in my cath lab, I would have done with Impella up front. If Impella is not available like it was the case here, I would have rescheduled it again for another day. But the patient was still symptomatic for chest pain, so we had to do that. And we decided to do that in a bailout fashion with a aortic counterpulsation. Old style.
Yeah, only comment over this point. Sometimes we decide to use Impella only the point. If you are left main, ejection fraction, and diastolic pressure. But I completely agree. Sometimes there is a borderline case in terms of clinical patient evidence. But if some lesion, okay, if you go directly in 50 minutes, you finish and you're happy, and I probably not matter Impella, put Impella. But if you have any problem like this, or if you prepare calcification, we are squeezing or long dissection, so to go and to work relax is better, I believe.
Yeah, also because we always deal with this is the topic of today: complex lesions, lesion preparation, calcific lesions, acute closure. Yes, but here the problem was acute mitral regurgitation. So probably we have to understand it. The cheap patient, it was a really cheap patient, not only lesions, related to lesions. Okay, I think what was the time?
But I was going to ask one question.
Yes, please.
The mitral regurgitation, did it improve after the PCI?
Yeah, it came, in the end, it came after, at the beginning. Yeah. So now we have the last presentation today, Dr. Andrew Ladvinek, using Pronavi backwards and forwards.
Thanks very much, and thanks to Brosmed for the invitation. So an interesting phrase was used about balloons not all being born equal. I'm talking about the Pronavi microcatheter, and certainly microcatheters are not all born equal, but there are lots and lots of them on the market now, and certainly they don't perform differently. So my brief today is to show you a couple of cases and how the Pronavi's performed. These are my conflicts of interest. Of course, this is a Brosmed-sponsored symposium. So I'm going to show you a couple of CTOs. I'm going to show you an antegrade case. I'm going to show you a retrograde case, and in both cases, I'm going to show you the utility of the Pronavi microcatheter. So the Pronavi microcatheter comes in 3 lengths, one 30 centimeters, one 50 centimeters, and interestingly, a longer one at 162 centimeters. There are those 2 tip types, one more akin to what you might be familiar with as a fine cross, where there's a kind of a blunt tip with a slightly lower distal profile of 1.7 French, and one with a tapered tip with 1.9 French, and the one we've got on the shelf is the 1.9 with the black tapered tip. So the first case, 50-year-old male, previous PCI to the circumflex in the right coronary artery. He's got angina despite 3 anti-angina. He's got a good LV, and this is his angiogram. So I'll show you the angiogram. I'm going to dwell on the microcatheter side of things rather than the stenting because that's the focus of the talk. So you can see there's a chronic occlusion of the LAD. You can see we've got a wire in a septal. You can see that there is quite a big septal that comes off that PDA, that comes in just by the distal cap. So we've got a blunt proximal cap. It's slightly ambiguous with that septal coming off. It's pretty straight. It's 15 to 20 millimeters, so it's not too long. And I think it's important to note that septal comes in just by the distal cap, both for if you get into it and also if you get retrograde, you need to be particularly careful to maintain access to the LAD, so when you come around that septal. So given those characteristics, the primary strategy was antegrade wiring. We've got an option for antegrade dissection re-entry and for retrograde should that not work. So here we've got a 130 centimeter Pronavi microcatheter, and we've got a Gladius EX wire. And I'm going to show you the wiring with the microcatheter to show you how it behaved. This is all stitched together. I didn't do all this in one go. I do stop and think about how things are going. But you can see the Gladius EX has moved into the CTO body there. You can see we're on the right track. And one of the things the Pronavi did quite well here, you can see that it's followed the wire, so we're able to get closer to where the tip of the wire is, which allows us to exchange wires if we need to, and also provides us with more tip penetration by having the microcatheter tip closer to the tip of the wire, which means when we get it on, get the wire on a little bit, and you can see we're right by the distal cap now. If we get the microcatheter a little bit further on, it gives us that extra tip force to be able to push on and wire the occlusion, which will just happen now. So what you can see is we've wired into that septal. So
So the question now is, do we just come back, potentially give up our ground and try and drop into the LAD, or do we follow it with the microcatheter? And you can see we followed it very well. We've exchanged out for a workhorse wire, and then we can very easily take a dual lumen microcatheter and deliver a wire to secure the distal vessel. So here you've got a Sasuke, I think that's a Sion wire. You can see we've just dropped it across into the LAD, and we've wired it without giving up any of the ground that we made. So we go on to predilate. As I said, I'm not going to dwell on this part. We stent the proximal vessel. We predilate the distal vessel and use a DCB in it. It's all image guided as well, but again, that's not the focus of the talk, so I'm not going to dwell on that. You can see that 2530 DCB, and then this is the final result. So a pretty straightforward case, but where the Pronavi performed pretty well with an antegrade wire strategy. On to the second case, which is a little bit more complex, using it backwards. So 55-year-old patient, he's got angina and exertional dyspnea, and he's got severe left ventricular systolic dysfunction with a dilated left ventricle, and that becomes important a little bit later on. There's global viability and anterior hibernation on his cardiac MRI. He was discussed with the surgeons and considered to be too high risk, and they weren't happy with the distal target on the LAD, so he was referred for PCI. So these are the contralateral setup pictures. You can see there's a blunt cap just at the ostium of the LAD. You can see the right coronary artery is diseased, and we'll come back to that. In the REO view, you see these septals. But what you don't really see is very much distal filling. You see the septals going to where you think the LAD is. So again, we've got a blunt proximal cap. It's slightly ambiguous. It looks pretty straight. You can see the calcification, and you can see into where that stent is. And it's really difficult to know where the length is. In fact, the whole course of the vessel is pretty ambiguous here. The one thing we've got to help is there is an old stent here, so we know, broadly speaking, what we're aiming at. So I think here, it's very unlikely we're going to be able to wire this antegrade and know where we're going. So the primary strategy was a retrograde one. But of course, you still need to make antegrade progress. So here we've got a turnpike and a Gaia 3 wire, and we do manage to get in close to the stent, but the wire's not free. We're certainly not in the lumen. And pretty quickly we decide to move to a retrograde approach. So here we are in an REO view. You can see we're wiring, this is a Sion black wire. We're in quite a distal septal, which again is relevant, and you'll see why in a second. So we wire into the LAD. You can see we're overlapping with that, with our antegrade wire, which means we're in a good place. The wires are dancing together. And then this is a 150 centimeter turnpike LP. And you can see it's struggling a little bit. So I've got two problems. The first is that the microcatheter won't cross. Now, I don't tend to use short guides, so these are 100 centimeter guides. And the second problem is I've only got about 2 to 3 centimeters left in the hub of the microcatheter. You see, I'm not even halfway across the septal, so I'm not going to be able to get that microcatheter all the way across. And even if I have a guide catheter extension right down to where the septal comes in, I'm not going to be able to externalize with that microcatheter. And not that long before this case, we'd got some of the long Pronavi, the 162 centimeter Pronavi microcatheters on the shelf. So the first thing we did, we took an Alveo HP 10 balloon and dilated the septal channel where we were struggling. And then we took a 162 centimeter Pronavi. And you can see it's really sailed up the collateral. So now we've got a microcatheter across, and actually once we had the microcatheter across, we were able just to wire retrogradely with a Sion black wire, using that antegrade wire as a marker. Again, we've come in partway down the LAD, so we use a dual lumen catheter to deliver another wire and secure the LAD. So you just drop the wire into the LAD, and so now we've secured the apical LAD. Now, the ostium of the circumflex was diseased, the left main stem was diseased, so there's a fair amount to do. So I've put it all in one. You can see that's a 50 millimeter pot balloon with the very short shoulders there. We culotted the circumflex in the left main. We used a DCB in that first obtuse marginal, and we also used DCBs in the distal LAD, which, as you can imagine, was pretty small and underfilled, but diffusely diseased as well.
So that was the final result at the end of the case, which I have to say for the apical LAD was pretty underwhelming. We had treated it with a 2.0 balloon. So this chap had a diseased right coronary. Actually brought him back a week later. And this is what it looked like. So a pretty nice case. That LAD has plumped up after treatment with a drug-coated balloon. And actually a result which, bearing in mind what we started with, I think is pretty acceptable. So really this was just a quick whiz through a couple of cases to show you the utility of the Pronavi microcatheter. I think you saw from the first case that actually for crossing a CTO body, it performs pretty well, and certainly my experience of it so far is that it does perform pretty well and it crosses pretty well, which is not true of all microcatheters. Used retrograde, they do cross collaterals well. They're braided microcatheters rather than coiled, so it's not a case where you talk it through. It's a case of maybe wiggling it a little bit and pushing, but they do cross well. And finally, having that 162 centimetre length can be useful. There are times when either when you've got a long way to go, or you're going via grafts, or you're going around a long epicardial collateral, where having that extra length of a microcatheter can really help you get a complex CTO done. Thanks very much.
Thank you, Andrew. Two very nice cases. I have to tell you that I completely agree with you as regards the second one. In terms of not putting stent in the distal part. So it wasn't an investment procedure, but you invested on that. You said, okay, it's gonna, there is some conflicting flow. Let's see it in a few days. And that's the way to do. And I would also like to add that probably you will see a lumen enlargement within the time in that area.
Yeah, I mean, it was unusual to bring the case back quite as early as that. So, if I brought it back 6 weeks, 8 weeks, 3 months later, it may well have looked even better than it did. But it's striking that after just a week, it looked as good as that.
Comments? How much time do we have? We have 2 minutes for comments.
We have 4 minutes total for the. I think you can go ahead with the.
I
think Professor Bernardo will now have a presentation on innovations unveiled, Brosmed new product preview. Before he starts, I'd just like to comment on this, that we had excellent presentations from all the presenters on different types of modalities used in complex procedures. And mind you, these procedures make them look simple, but they're all done by highly experienced operators and highly complicated procedures. And I think the basic thing lies in the planning of the procedure and the use of the of proper catheters and proper materials that optimize the results. Over to Dr. Bernardo.
Yeah, thank you. I would like to thank Brosmed for making this session appear. This is the first one, if I'm not wrong, that Brosmed is organizing at EuroPCR. So welcome again to Europe. You are in Europe since a bit, but organizing this type of activities is not so easy. So congratulations. We have seen the ability of these different devices from Pronavi, Alveo HP for CTO, POT. We have seen the Artemis balloon for an all-comer case, and Wedge NC, how they can simplify those lesions that are really complex in our daily armamentarium. And dealing with these cases that we have seen, it's not so easy. So having the devices that will respond to all of these needs is very important for us. A glimpse into the future, Stefan already showed you a slide on this new device that will come in Europe, I guess, around Q1 25. This is a new generation scoring balloon going much more versus the cutting balloon with this short 19 wires, but with a triangular shape that is, as I said, rendering it more cutting but more deliverable than a cutting balloon. So this is a device that I will be happy to test as soon as possible. And then this is my last slide. I would like you to understand and always remind that if we take the entire time that we dedicate to a complex lesion, first of all, we have to assess it. So dedicate your time to understand the lesion. Use intravascular imaging, understand the angiographies the better. And then the job is done when you prepare the lesion, okay? Again, I'm not talking about a STEMI or an easy lesion setting, but in a complex lesion setting, you have to prepare it because that is related to the outcome and to the future and to the fate of the patient. And then the last part of the time, it's easy. You just deliver the drug-coated balloon, you just deliver the drug-eluting stent, and the job is done. Thank you again for your attention.
Thank you everyone for having attended this session. Thank you to Brosmet for this wonderful session, and I thank all the speakers. It was a really educative session that we had, and thank you all very much once again.